appreciate you taking time out of your busy schedules, and we're just overwhelmed by the number of people who have expressed an interest. I think we have over 350 people joining us today, so that's phenomenal, and it shows a commitment on everyone's part to really ensure that we have quality care management, that we have good, positive provider relations. So we do appreciate you joining us. We hope this will be the start of a series of webinars that we can do that provides information to our provider partners. So I'm going to keep my remarks fairly brief. About a year ago, LifePlan and ACA announced a strategic partnership. We formed a management services organization and really started looking at how do we invest in providing quality care management services, and how do we work effectively in a positive way in building better quality relationships with our provider partners, because we know that in order for us to provide quality services, we have to have our provider partners. And, I'm speaking to you not only from a CCO perspective, but also I was a provider for 15 years, and I'm a parent of a child who receives services. And I couldn't be here right now if it was not having a dedicated provider and a care manager who work together to develop a good program of services, a good plan for my son. So I appreciate all of you being here. So our goal today is really to share more information with what we're doing to invest in both care management as well as in provider relations. And I hope, again, that you'll find this to be of value. We all share a common goal of making the quality of life and the health of people with IDD and the support that we provide their families a priority, and to improving their quality of life in our community. So you being here is a start to hopefully what, like we said, is an ongoing dialogue. So thank you again. And with that, without losing any more time, I'm gonna turn it over to the team. Lori. So I'm going to introduce Lori Kiersing, who is our VP of Strategic Initiatives, and has actually been very much involved in building our provider relations team. Are you on, Lori?
All right, I think I have to hear something.
Lori's here. It looks like you just have to unmute.
Okay, yes. All right, thank you. No problem, John. Yeah.
Lori, if it's easier, I can share my screen. I think you just have to unmute your mic so that we can hear you. There you go.
All right, yeah, I could not get it to unmute. My apologies. Yeah, if you can share your screen, Alexa, that would be great.
Yep.
So I'll just wait for the slide to come up with our directors of provider relations. There we go. Oh. There we go.
Is everyone able to see my screen? Or is it black?
Not yet. We could see your email, but not the slides.
Okay, let's try again.
Sometimes WebEx is a little finicky with the with sharing content.
Okay, I'm gonna stop and reshare. Sorry, guys.
There we go. Now we can see it. So if you can jump to the slide with the names of the directors on it, that would be great. Thank you. There we are. Okay, so I'm sorry for that delay, we're not going to spend a lot of time on this. Just thrilled to have everybody here, as Nick said, at our first, what we hope to be one of many presentations and discussions. We wanted to just, introduce quickly the 6 directors of provider relations that we've brought on. We're thrilled with the team that we've assembled so far. 4 are with us now. 2 will be joining us in a couple of weeks, and that'll round out our team, 3 in each CCO. So Karen, I don't know if you're on camera, but if you just want to let people see who you are, Karen Hoffman is covering, actually, if you want to switch to the next slide, Alexa, that might help. Yeah, so this map kind of lays out where the different directors of provider relations are. The light blue at the top is Karen. You're going to notice huge differences in the numbers of counties, and that really has to do with the numbers of providers, trying to balance the scale so that they're all working with about 50-ish, give or take, providers, so that we can give the attention to the providers that we need to. So Karen, I don't know if you're there, but we have Karen Hoffman covering that North Country there. The middle medium blue is Ann Seepersod, who many of you I think know. She's been with Life Plan CCO almost from the beginning. Moving down into the darker blue, that's Nadira Bryan, and she is covering the Hudson Valley. And then Nadira is also helping with the ACA providers who overlap into the Hudson Valleys. Didn't make sense to have 2. So she's covering all the providers in the Hudson Valley. And then when we move down into the city and Long Island, Megan is covering part of the city, and a new person, Crystal Presido, she's actually part of ACA now, so knows the CCO world and the provider world well. She'll be covering the other part of the city. And then we have Angie Monroe, who'll be joining us in a couple weeks to cover Long Island. All of them have extensive backgrounds in the IDD field and know CCO, health home, and it can be good resources to you, even if it's just, helping you link with whoever it is you need to speak with about whatever issue might come up at any time. All the information is on the website. It's also in the slide we just had up. So, please feel free to check out their bios on the website, reach out to them at any time. Even if you get the wrong one, it doesn't matter. They'll get you to the right person. We just really want to have that communication and constant contact. If you haven't met them already, you will be hearing from them very soon. Just moving down quickly into the meat of this program. We just want to have you hold your questions until the end of the webinar, if you wouldn't mind. Put questions in the chat box. I think things have already started to pop in. I know Jamie, who's going to present this next section, is going to move pretty quickly so that we can leave as much time as possible for discussion and questions at the end. So again, put those in the chat box. If we can't get to everything, we'll follow up later. The slides, the recording, the questions, it'll all be on the website as soon as we can pull it together to put up. And we're going to use the information that we get from the conversation today and the questions to help us plan future sessions. So with that, thank you, and I'll pass it on to Jamie.
Hi, Lori. Thanks so much for that introduction. Good afternoon, everybody. My name is Jamie Madden. I'm the Chief Operating Officer at ACA and Life Plan, responsible for the care management programs there. So today we wanted to start off with the basics and really go through our expectations for the role of the care manager. And like Lori said, there's probably going to be other additional webinars that we want to expand on certain aspects here, but we're really starting from, we want to make sure everybody's on the same page around the role of the care manager. So I'm going to cover some, basics and some like detail-oriented stuff. I'm not going to read through everything on the slide because the slides and the recording will be provided after this, but I'm going to try to hit on some key points so we can get through this quickly. So next slide, please, Alexa. Thank you. So just kind of baseline setting, overview of the CCO Health Home Care Management Model. As a reminder to everybody, it was implemented in 2018. I don't think we, as providers on this call, you need a reminder of that, but just kind of where it was coming from and why. It was implemented in 2018 in replacing the Medicaid Service Coordination Program. And this was done at a federal and a state level, really to focus on conflict-free care coordination. And one of the things about the health home care management model is that it's an evidence-based model that really focuses on achieving positive health outcomes for people who are enrolled in a health home. And so it was a big shift for MSCs who really focused on ensuring Medicaid was active and that services were in place to really focusing on achieving positive outcomes and making sure that we're coordinating all care, healthcare, behavioral care, and developmental disability services, and that we're also really focused on preventive, preventive services that could stop problems from getting worse or developing in the future. So I think, when you look at it today, 4 years later, we're still in the midst of that shift in some ways. But that is really the goal of the health home care coordination model at both ACA and Life Plan. We are focused on achieving positive health outcomes for everybody that we serve through coordination, comprehensive coordination of all of the services. So next slide, please. So let's talk about how we do that. Some of the basics of the role of the health home care manager is completing a comprehensive assessment process. This is part of the person-centered planning process and should be person-centered in nature. Through that comprehensive assessment, we're going to develop an initial life plan that is necessary for identifying needed services, but is also meant to guide the service delivery, including allowing us to apply for HCBS waiver services, identifying appropriate service providers, and connecting members through the entire course of their lives. We want to make sure that we're including medical providers, behavioral providers, community supports, and community services. And so I know there was a question earlier, what do we mean by providers? And our provider relations folks, Lori, correct me if I'm wrong, but I believe we're focusing first on OPWDD providers. We really want to make sure that we're partnering with our OPWDD providers and making sure that we're meeting needs on both sides. But through a comprehensive health home care management model, we do need to look at medical providers, behavioral health providers, and others as well. So
Yes, you're correct, Jamie. Sorry, and I did respond in the chat box with who we're referring to as well. Thank you.
in addition to developing that initial life plan and ensuring that services are identified according to the person's needs and wishes, we reevaluate that life plan on a regular basis. We are here for helping to problem solve when crises arise with different members, assisting with transitional planning, including transitioning from school age to adult systems, transitioning out of a hospital setting, transitioning out of other types of settings. We do still do the work of applying and maintaining for benefits and entitlements. And of course, as I keep saying, we advocate for members' health and wellness. We also have a responsibility to report incidents when applicable, and we have to always be supporting the health and safety of the folks that we serve. So that's really, like, if you think about the key roles that a care manager is intended to play, that is how we define the role. When we look at the comprehensive assessment process, I know that there's a lot of questions usually around what encompasses a comprehensive assessment process. And so we wanted to be clear with this group and anybody else who views this recording on the website that our comprehensive assessment process is defined by regulation as encompassing the following plus anything else we can find. The PATHS assessment, which you might have also heard of the IM assessment. This is essentially the assessment the CCO is required to perform, and they go by different names depending on the EHR that you use. But Life Plan and ACA both use CX360, so we have a PATHS assessment. We also have the DDP2, which is required to be completed every 2 years by the care manager or as needed, and by waiver providers. We have the LCD, we have the CAS and the CANS. Depending on the age of the person, you'll get one or the other. But then we also look at all other assessments and evaluations that are available. So that might include IEPs, it might include medical, psychological, psychosocial, anything that we've received through the course of serving someone that we have in their record. And it's really, again, it's meant to inform a very comprehensive service plan through the life plan process. So that's why we look at all of these different elements. So once we get through the comprehensive assessment process, which I know is sometimes hard to explain to members and families, we use all of that information to develop a life plan. And this is what you should expect from care managers through the life plan process. In advance of the meeting, our care managers develop a draft life plan. so that there's a conversation starting point. And we should be sending these to the member, the representative, and the provider in advance of this meeting. The care manager then should be working with the member and their representative, as well as providers, to identify the day, the time, and the place for the life plan meeting. I know we've gotten a lot of feedback around notification, around meetings and things like that. So I just want to reiterate that care managers are supposed to be working with the member and their representative first. Again, through the person-centered planning process, we want to make sure that the time, day, and place works for the member and their families. But that does not take away from the fact that the care manager should also be coordinating with critical providers in advance of the meeting to make sure that everybody can be there and can contribute. Similar to the comprehensive assessment process, we want to make sure that we're getting the viewpoints of everybody serving this person and their circle of support. The care manager is going to work with our member to identify who they would like to see in attendance. And service providers are always invited, and of course we want you there. But another key important piece of regulation is that the member does need to be present in order for us to consider it a life plan meeting. Next slide, please. Once we get to the meeting, any assessments that were conducted, any staff action plans, self-direction budgets, other relevant documents are reviewed at the meeting. We are all coming together to discuss what services will best serve the person in front of us, what our desired outcomes are, what their desired outcomes are, what their goals are, and who would be the best to provide those services. So the life plan meeting is really intended to ensure that everybody's on the same page around who's doing what for the person. We are required to have a signature for members and representatives for life plan approval, and providers should also be getting updated draft life plans for feedback. Once the member or the representative approves, the provider can give their acknowledgement, and then we are doing this process again on a semi-annual basis. Annual and semi-annual life plans need to have member and representative approval within 45 days and provider acknowledgement within 60 days. I know that some of the timelines have become questions, so we want to make sure that we went over that with you all. In this, we talk a lot about the alignment of the life plan and the staff action plan, and I know that is another area where we get a lot of feedback from providers. Goals, levels of supervision, tasks, and supports may be assigned to providers following the comprehensive assessment process, but they should be reviewed at the life plan, and ultimately everybody should be walking away from that meeting with the same understanding. So the goals in the life plan are in general language. They're not going to exactly match the staff action plan. The staff action plans are really intended to spell out how the provider will be delivering the outcome. And if the life plan doesn't match what's in the staff action plan, it should not be a billing issue. But we know that this comes up a lot in terms of discrepancies. And so we do have a dispute resolution process if service providers don't agree with the content. Both organizations have a specific dispute resolution process, but we also can certainly help explain some of the many regulations that we have to navigate around the life plan. Once we have a life plan that has been approved and acknowledged, we need to use that document to apply for services. Ultimately, OPWDD is the one who authorizes the services and approves the units. I know that this comes up a lot too, because folks think that it's, you know, a holdup at a care management level around authorization of services. Frequently, we're kind of stuck in the back and forth between authorization of approved services and approved units. But ultimately, once we get approval, we're going to reach out to providers and discuss the delivered service, discuss the desired service and how we can deliver it. And then we're going to, we use the RSA and the SARF to get those services authorized. So I know that those two acronyms probably come up a lot in your day-to-day work with care managers, that those two documents are required for us in order to get services authorized. If services are approved, but we want to change or add service units or hours, care managers have to complete a new SAR form. And the care managers are responsible for informing the providers of the waiver NOD. We have to send it to the providers to initiate or modify the services. That is very much within a care management responsibility. And of course, any changes to services need to be reflected in the life plan and will require an addendum to the life plan. So that kind of goes over the life cycle of the life plan and the subsequent applying for services. Another common question we get is, how frequently should visits, contact, and communication happen with the care manager? And we lay out in very much detail what that looks like in the next couple slides. But before we jump into that, just want to make sure we're all clear on terminology. So face-to-face is defined as talking to and seeing the member at the time, place, modality of the member's choosing. So it can be either in person or via telehealth. And as you guys know, we have some flexibilities through the health emergency, but we also have some new guidelines around telehealth. Sorry, I'm getting a little bit of feedback. So face-to-face can either be in person or via telehealth. If it's in person, it means the member is actually physically in the same room and the same location as the care manager. If it's telehealth, our COVID regulatory flexibility allows us to use the video like we're doing today on this webinar or telephone connection to meet face-to-face requirements. Post-COVID PHE regulatory flexibility, it will have to be using video. So everyone enrolled in comprehensive care management is entitled to a monthly service, and the member's tier determines the minimum visit requirements. This is all laid out to us by OPWDD, and it's really not something that care managers can change or modify. So the tier is determined by Carolyn and Mary Beth, the completion of the DDP2. Just want to make sure I'm
Sorry, I'm unmuting. You know, the DDP2 heavily weighs it, but there's still an algorithm that kind of goes into play with some other factors that would be, you know, considered, such as if they have self-direction or some other things. But the DDP2 is the heavy driver.
Right, and so the tier really is what pushes the monthly billable contacts. For tiers 1 through 3, we are required to have a monthly billable contact, and quarterly those contacts need to be face-to-face. And we are also required to have annual and semi-annual life plan meetings in person. For tier 4 non-Willowbrook, monthly face-to-face visits. OPWDD has talked about an option of opting out of monthly face-to-face visits if the person does not wish to have monthly face-to-face visits, but that has to be an active conversation with the member. And quarterly, we have to be in person, as well as having our annual and semi-annual life plan meetings in person. For Willowbrook class members, monthly in-person face-to-face visits, no opt-out option, and obviously in-person annual and semi-annual life plan meetings. For our HCBS basic services, we only have 2 required meetings and 2 emergency meetings. So the required are the annual and semi-annual life plan meeting, and we can have contacts up to 2 additional times a year to address unexpected needs. So the basic program is really our lowest level of coordination. And we do have to do it on a quarterly basis. So just, you know, calendar wise, it works out quarter 1, 2, 3, and 4, the way it's laid out here. And after the PHE ends, again, only video is going to be accepted. Right now, we do have some flexibility using video or phone. I know some folks struggle with figuring out WebEx and Teams and all of that. We're not going to have that flexibility once the PHE ends. So just reiterating that. And then for tiers 1 through 3, with the COVID flexibility, we can substitute in-person visits with telehealth modalities. That's basically the difference in this, is the telehealth modalities as a substitute for in-person visits can be used until the PHE ends. But after that, we're going to have to go back to the telehealth defined as video with sound. And we're still going to have to do the annual and semi-annual meetings in person and the quarterly requirements as laid out in the earlier slide. And then Willowbrook class members, again, they have to be in person face-to-face visits every month for obvious reasons related to the legal implications. So those are our face-to-face and service requirements for anybody based on tier. Alexa, I don't know if there's any more slides after this one. No, there isn't. Okay, cool. So I can turn it back over to Lori to talk about some of the provider, the changes in response to provider feedback that we've received through the meetings they've been doing. And it looks like we wrapped up in a good amount of time to have some nice Q&A.
Great, thanks, Jamie. That was really helpful. So just wanted to let you know that we have been listening, not just recently, but really over the 4+ years we've been in operation, and that's led us to make some changes. In particular, just creating a provider relations department and staffing it the way we have. You know, we feel like the relationship that we have with our providers is so crucial, as Nick said, and so we really want to put more energy and effort to that. We're doing, hopefully, as I said, you're getting outreach from your director of provider relations, and if you haven't, you will very soon. But that's going to give us improved communication about specific issues or general issues at individual provider meetings, through our monthly newsletters, which we've kicked back up again. We've had 2 out, I think, so far, October, November, and we hope to be on a monthly cycle with those. And also these webinars, which we'll do as often as we need to. We also, I think, we're going to have a call center at LifePlan. ACA providers are probably familiar already that they have a call center where, you know, if you don't know who to call or you need something quickly, you just need a copy of a report, whatever it is, you can call the call center number and someone will either immediately help you or get you to the right person who can help you. We're going to have that same model at LifePlan because we feel like that's important to give people a single point of contact and quick and easy access. But also your directors of provider relations will always be a contact for you at any time. And then the community resource tool, if you're not familiar with it, it's on, again, you can access it through either website, and it's just a great tool that you need to be on it. We need to be sure you're on it, your services are correct and contact information, that sort of thing. But it's just a way to get your services out there in front of staff, in front of members and families. It's very easily searchable. If you're looking for an attorney in Albany or whatever, or you're looking for a healthcare service, if we know about them and they, you know, we know that they serve our folks, we try to have it in the community resources tool. But that includes, you know, all of our IDD programs and services as well. So we have it now up and running. We've had it at LifePlan for a while, and ACA is in the process now of bringing it up for their members and staff as well. Do you want to move to the next slide, Alexa? Okay. And then we are in the process right now of creating a new care manager institute, or a care manager institute, which will be new for the CCOs. And it will address new care managers, but also, you know, current and existing care managers. And we're doing that really to advance the skills and training of our workforce, but also to allow room for advancement and retention, greater staff, you know, satisfaction around their work. So there's a lot to come. That could be a whole webinar unto itself, but I know Jamie and her team are working very hard on that. And then we're also looking at other recruitment and retention strategies. And part of this, it'll be part of the Institute, but adding an apprenticeship program where we can, you know, if we have people out there who maybe have the bachelor's degree but don't have the experience that they need, or however we can help them to get over that hump to qualify to be a care manager, that we would work with them to get them to that place. So we're looking at some grants that would support us in doing that. And we have been doing, and we continue to do, and we'll, you know, hopefully do even more joint advocacy with the state at all branches of the state on issues of common mutual interest. So those are just a few of the things that we've kind of put in place or continue to do hopefully do more of into the future. And I think that that is it for the formal part of the presentation. We have there's links to the websites, a little more information because people often have questions about the cast, so we included that in there as well. And I think at this point, Megan was going to help us get through the Q&A.
Yep.
And again, just keep putting questions in there.
Yes, please definitely share your questions in the chat box. That's going to be the easiest way for us to answer them just because we have so many people on this presentation today, which is wonderful. So we've had a couple of questions asked a few times. The first one is whether this presentation will be recorded. So yes, the presentation is being recorded, and we will be able to share that recording link with you most likely tomorrow. It takes a little time to download everything. Then the other question is whether the slides will be shared. So we are going to share a PDF of the presentation. We're going to be using the email that you used to register today. So everyone in attendance will receive that as well. So let's move on to the other questions. Let's see, we've got a few. So providers, like we said before, for the purpose of this presentation, when we're referring to providers, we're really mostly referring to agencies who provide one or more OPWDD services. That's really where our focus is right now, but we also have been, obviously, we do interact with some home care providers and other medical service providers as well, with the assistance of our clinical team and our member outreach team. So the first thing I want to address here. So incident reporting is confusing and problematic. Many care managers throughout the state and at all agencies are confused by the process and how the reporting system works, especially when the member lives in an OPWDD certified setting. This alone needs an entire presentation. Please consider. It's not really a question so much as a comment, but I just wanted to bring that up because we do want to encourage you. If you have ideas for future webinars, absolutely ask. So that's something we can definitely add to the list.
Yes.
Let's see, next. Are care managers required to be in attendance to pre-planning meetings, such as meetings when the budget is being developed by the individual supported and the support broker? So I'll let someone field that one.
Hi, it's Carolyn. I can answer that. I think it seems like it's specific to, let me just make sure I'm looking at it and read it correctly. Specific to budget, is that right?
Yeah, it's the pre-planning meetings it looks like it's specific to sales direction.
Okay, I lost it on the chat here. But yeah, I mean, I would say anytime, that the care manager can come to a meeting, that would of course be preferable. Is it required that they're there, and would it hold it up if they're not? No. They should be invited obviously to all meetings, and that would be great. There's multiple meetings as it's kind of leading up to those final meetings. So I would say definitely make sure the care manager is invited, and they will certainly attend where necessary.
Yeah, the only other thing I would add is just that, we're always doing so in alignment with the person's requests and wishes. So we want to keep person-centered planning at the center of it, but certainly I think it's important for us to be at those meetings, and care managers should be attending those when requested, definitely.
All right, great, thank you. So the next question, members and families are told that the life plan has to match the staff action plan. Is that true?
So the life plan is more of a general document. The staff action plan spells out the specific actions of the provider. I know that's an area that's been a gray area with a lot of confusion around it. And it leads to a lot of the disputes that we get directed our way. So Carolyn, I know that we get this question all the time. The life plan is really meant to be the general document guiding how care managers are requesting the service, and the staff action plan is the document where guiding the services the providers are actually giving.
Yeah, because if you look at the goal that's in the life plan, it's going to be a little broader, where the staff action plan is going to be more granular. So this very specific goal itself for the family, for the person, and that that the person has chosen, is going to be a little bit more, like I said, it's going to be a little more granular than what is a little bit more of a broader goal within the life plan. So having to match exactly word for Word would not be required. I guess I would want to know, because I do see the question kind of says that the members and families are told that. So just a little more background, maybe where that's coming from and where we could help kind of dispel that and give some more, clarifying information would be helpful too.
Thanks, Carolyn. Next question, to clarify, so this was answered in the chat, but I'm just going to read it out loud for everyone. To clarify, a SARF or RSA is what the care manager completes, and OPWDD's approval response is the NOD. Yes, that is correct. So after the SARF or RSA is approved by OPWDD, they then send out the NOD.
Can I just add that we do
Sure.
sometimes need information? I'm sorry, this is Lori again. We do sometimes need information from programs to complete those forms. And sometimes we get requests back for or denials from OPW that we need to react to, and it requires information or updates from providers. So the care manager definitely leads a process, but it needs to be done kind of in partnership with the providers as well. And actually look for in our December newsletter, we hope to focus a little bit more on the SARF process. And if we need to, we're happy to do a webinar at the beginning of next year to talk about this more, because I know this is an issue for a lot of people. Thanks, Megan.
Thanks. Next question, can a member create their own personal outcome measure or goal that is not in a drop-down menu in the Life Plan electronic system? So
no, unfortunately, POMs are prescribed from, the Council on Quality and Leadership, and those are pre-stated items within there. So the POMs are there to be selected and kind of drive everything else that goes into the goal section of the Life Plan.
Thanks, Carolyn. Let's see. So this is not so much a question as a comment, but something that we could definitely discuss. At times, there are needed changes to services that are not being made in the Life Plan. People then need to wait until the next review cycle to add this information to the Life Plan instead of an addendum being done. So that is the comment. It's not a question so much, but I guess, when changes need to be made to the Life Plan, obviously an addendum is an option, but I'll let someone with a little more experience talk to that.
Yeah, I mean, I think it links a little bit to that earlier question about if the Life Plan has to match the staff action plan, probably, if I had to guess, and requesting certain addendums with the Life Plan to better align with changes to services through the staff action plan. That would be my guess about that statement. But it's hard to know. So if the person who entered that, if you have a specific question around this that you want to just drop in the chat.
Sure. Yeah, that would be great.
Okay. And Jamie, this is Nick. Wouldn't it be true though that the reason why we try to write the Life Plan as a broader document is so that as changes occur, you can manage within it without having to necessarily make a major change to it.
Exactly.
All right, great.
Yeah, I'll just add to that too. I mean, I think depending on what's being asked for, I would say it's probably depending on the timing. So if, a Life Plan, if an identified change comes up and maybe the Life Plan meeting's next week, maybe that would be a reasonable reason to say, okay, we have a meeting coming up in less than a week. Let's just hold rather than having to do an addendum and, we have to get all the approvals and we can make the change at the time. But clearly as a provider, if there's a change that's really identified, say it's something billing critical or something that gets caught, there absolutely would not, and should not be a reason to be holding up on that. And the care managers, for both agencies, should be responding quickly to you and getting that done for you and getting the necessary approvals to fix any, glaring errors that might need to be corrected. So there's probably a spectrum of reasons of why a change might need to be made, and that might really dictate maybe the response that's given, if how critical it is versus maybe an update that can just wait a little bit. So,
and we did get a little more information in the chat. So the question was asked about adding in a needed waiver service. So it would be a new waiver service added to the Life Plan. So in that case, yes, I mean, an addendum
Yes, especially
Yeah.
if the service is
Absolutely.
starting, for sure. Yes.
Yes,
Absolutely.
absolutely would require an addendum.
Mhm. Okay, great. Thank you so much. The next question, if a member is in a behavioral or health crisis, is the care manager the lead person on this? Does the tier matter at that point, and how is it decided? By that, I think I mean who is going to be the lead on managing the crisis. How does the care manager work with certified residential providers on these issues? Who would be the lead in that situation? So this would be, I guess, a multifaceted question, whether you're in the community or if you're in a certified residence.
Yeah, but I think the general answer I would give to that is that the care manager should take the lead in coordinating across various providers who are addressing a behavioral or a health crisis. So care management, we provide 6 core services. And those services do not include actual service provision in a crisis or, therapy or things that other providers are licensed to provide. But we are responsible for communicating with all the providers in alignment with the members' consent and ensuring that we have that consent appropriately filled out, and making sure that all of the providers are on the same page, particularly when a member is in a crisis. The tier, I'm not entirely clear about the tier question, but in terms of can a care manager communicate with people outside of the 1 service a month, regardless of tier? Care managers can always do more than what was listed on the slides that were presented. So if there is an acute crisis and the care manager needs to be present to help coordinate an in-person meeting at a hospital or something like that, they absolutely can do that regardless of whether or not they've met those other requirements. Those are just the minimum of what we need to do. But our team should always be achieving quality services by meeting the members' needs. And the tier, it doesn't really change that. If the member needs the care manager should be there. And the lead in coordination, regardless of whether it's a community or a residential setting, is the care manager. I hope that makes sense to answer that question.
I think so. I think it's a great answer. Good answer. So next question. Will there be a presentation to teach families about the different sections of the life plan? Families tend to glaze over the document, and the transition to the core platform generates a life plan that is more difficult to read and for families to understand the purpose. So I do think we do offer member and family forums on a monthly basis. So this could be a great topic for us to address in a forum. So that's something we could absolutely discuss with our member relations team. And then there's another part to this. The new core life plans should be reconciled to the last finalized life plan before being sent to the team. I'm not entirely sure if that's an issue with just transferring the from the one EHR to the other, if that's a data transfer issue. But the last life plan, the last finalized life plan is accessible to the care manager. When we made the switch from Metascad to core, the care managers were able to access historical documents in Metascad, and we've migrated documents over to core. So the information should be there. That's the short answer. I don't know if anybody wants to add more to that.
No, I think you're right, Megan.
Okay, all right. So are ACA care managers aware of these guidelines for approvals, distribution, wording of valued outcomes and goals, that virtual meetings are considered face-to-face, et cetera? So our care managers are I mean, it's part of our staff development, our orientation. Our care managers are aware of what all the guidelines are. If there's ever any kind of refresher that's needed, if you feel that, if you're a provider and you feel that you're getting a little back and forth, you're not really sure if the care manager is giving you correct information, the care manager supervisor email, the email is usually in the care manager's email signature. If for some reason it's not in there because of an IT glitch, you can also reach out to our call center, and then they can tell you who the supervisor is if you need to speak with that assistant director to get a little clarification. And if you're finding that this is a really common issue that you're running into, that's a time where you could also put the director of provider relations on that email, because we can also reach out and coordinate with the care management teams to make sure that we don't have a gap in in knowledge there, and that if there's an opportunity for retraining for our care managers, we obviously want to take that. Next question, what is the federal PHE? So that is the public health emergency that we've been under since March 2020. So that is expected to be lifted, and we're not expecting it to be extended again in January, but it is going to, right now it's going through January 13th, I think is the date, if I'm not mistaken. So there were, what's the word I'm looking for? There were provisions made during the PHE that allow for services to continue. So obviously, like Jamie had discussed earlier, once that PHE ends, most things are going to go back to normal except the telehealth service that we'll be able to provide via video. Next question, OPWDD issues a Q&A, and one of the questions is whether the language in the staff action plan needs to be, okay, so never mind, we already addressed this, needs to be listed exactly as in the life plan. So it does not have to be listed word for word, but the general idea is that the goals in the life plan are going to be, they're going to be in line with what's in the staff action plan.
Hey, Megan,
Won't have-
the other part of this question, though, is that the Q&A, the OPWDD issued Q&A says yes, with an example provided.
Right.
So I think if whoever typed that in, if there is a specific document that you can point us to around that, we would be happy to clarify that with OPWDD.
You can, if you do have a question, further questions about that or the document, you could reach out to any of us via email, and I'll make sure our emails are in the chat box too. So next question, is ACA NY and Life Plan CCO the same organization? So the answer is no, we're two organizations, but we are in a managed service organization together. We do have one CEO for both organizations, but we each still do maintain our separate boards. We have our separate identities. We are in the process, we've been in the process of aligning all of our policies and procedures so that we operate in a similar manner. But we also know that Life Plan CCO covers upstate New York, ACA covers downstate. We know that things are a little different in New York City necessarily than they are in some of the counties, even on Long Island. So there are maybe some things that are done a little bit differently just depending on how OPWDD operates in that region. But generally, yes, we're two separate organizations that are functioning together. Does anybody want to add to that?
Yeah, Megan, I would say that the intent of us keeping the two separate CCOs, but yet making investments that we can, gain scale and efficiency and focus on improving quality of training, quality of provider relations, et cetera. So where we're able to gain some efficiencies, we're able to invest those efficiencies in improving quality of member service. But they're two separate organizations, separate boards, separate compliance function. So.
Thanks, Nick. Next question, how are you supporting the DSP workforce crisis? There is no care management without DSPs.
That's absolutely right. I'll take that one, Megan.
Okay.
We are absolutely in lockstep with the providers in advocating for, a living wage for DSPs. I mean, it's a profession. I couldn't be here if it was not for my DSPs. So we all recognize that we can't coordinate services unless there are DSPs providing those services. So we are very much in lockstep. We've been working together with NIDA, the CCOs, and the provider associations have been having regular meetings. We have a joint meeting with the commissioner coming up where we talk about these issues because, again, all of us are highly dependent on there being a qualified workforce that can support our population.
Thanks, Nick. Okay, next question. Is there going to be an actual policy or specific language for what qualifies as sufficiently inviting providers to life plan meetings? The day before or morning of or after the meeting has actually started is not adequate notification for staff who have many people on their caseloads. Obviously, yes, that's true. You should be notified of the life plan well in advance. I will let someone on the care management side take that question for me.
can jump in.
Carolyn, I see you getting ready.
I mean, I can jump in. You know, I can say we have internal policies on this. So I think what you're citing here is maybe some things going outside of that. I think what we would just want is to get some more feedback from you if that's happening. That should not be happening, of course, you know, the day of. It should be a full coordination that's happening, you know, approximately 30 days before the meeting, checking availability, sending formal notices out as to when it's scheduled, and making sure all parties that need to be there and that are requested to be there by the person that the care manager is taking the lead and coordinating that very proactively ahead of time. So, you know, definitely, if you're experiencing last minute notifications, that shouldn't be happening. And we definitely want to be able to address that and send out some reminders to our workforce about that. So please feel free, you know, to reach out if there's any specific instances as well that we might need to be aware of where we have to target, you know, some more follow-up.
Yeah, and Carolyn, let me say something here to be really specific. So again, you know, we strive, both organizations strive to provide quality care management, quality person-centered planning, making sure that we have full participation of the member, anybody else they want to invite to the planning process, as well as certainly the providers. You can't create a quality plan without the engagement of the providers who are ultimately going to deliver the service. We need to allow time. If you are finding that you're not getting sufficient invite or anything that is interrupting the provision of quality care management, quality services to our members, please report it to us. Let us know, send a message. We need specifics. We need to know who the member is, what the date is. But we invite you to let us know if something isn't right. And hopefully, you know, you would want us to tell you if something wasn't right. So we encourage that. I mean, we can only get better if we get that two-way dialogue and we know specifics, because we can't react to general statements. We need to know specifics. So Lori, when Lori put up a list of provider relations, you could either send it forward to, in the case of ACA, Carolyn, in her team, the 3 regional VPs, or in the case of Life Plan, you've got Mary Beth Redmond and the 3 regional VPs, or our provider relations people. Just give us, we'll get it to the right person and get it and get the situation corrected going forward.
And that would address the comment above too that I think we missed. If you're not getting the input and involvement in the life planning process that you should, same thing. We want to know the specifics.
Absolutely.
Yeah, there's a couple other questions further down around like changes to staff and things like that too, related to invites to the life plan. And I think the bottom line is, regardless of what's happening at the CCO, you should be invited to the life plan at the time when it's being developed, and you should have sufficient notice to participate. You have the entire leadership team here telling you that we believe that your participation is important, and our team should be following that, and we want to do something about it if they're not. So there are a number of questions kind of speaking to some of this theme, and I think that we are happy to address any instance that's brought to our attention.
Right, so we only have a couple of minutes left, and I know we still have a lot of questions. So what I would like to do is put together an FAQ document or a question and answer document that we can send to everybody after the meeting. It might take us a little bit of time to get that to you, but we will make sure that's done. We do that with our family forums too when we run out of time. So hopefully that'll be helpful. I do want to ask one more question that I've seen come a few times in this chat. Care managers have told providers that they must have 3 or more valued outcomes for the service on the staff action plan. Is that correct?
I'm just looking at that. I'm trying to find that question, Megan, because I didn't hear it completely. You cut out. What did you say?
Sure.
It's about halfway down, Jamie.
Sure. Yeah, it's care managers are told the providers that they must have 3 or more valued outcomes on the staff action plan. That's a requirement. And then we have another one later asking if there is a minimum requirement. They were told 3 goals and a minimum of 1 support.
I believe it's 3 goals and 2 supports, right?
I want to confirm it before I
Yeah,
answer.
or did
It's
I know,
okay.
I know there's definitely a requirement. I just can't remember.
I have an assist on the side here from Renee Manza. 3 palms and 2 goals.
Yeah, 3 palms, 2 goals.
Okay.
That's required in the, the health.
That's just for
and
the life
CCO
plan,
manual.
for the life plan itself.
Yeah.
Okay. So, go ahead.
One other quick question that I saw somebody said, do we have an age limit as to who we serve? And CCOs can serve anybody who's got OPWDD eligibility and Medicaid that is not receiving care coordination from some other entity. So it's difficult to do it. You can't do it with children in early intervention unless you get the consent of early intervention to basically back off. But we do provide services to children as young as 3 and people as in their 80s and 90s. So the whole lifespan for any CCO.
Thanks, Nick. Okay, so all right, so that's gonna conclude our presentation for today. So again, we will send out a question and answer document to everybody. We'll send out a copy of the PowerPoint, and when we send that out, I'll also make sure you have all the contact information that you would need, any pertinent contact information that we discussed today. Okay. All right, well, thank you so much, everybody, for joining us. We hope that this was informative, and we look forward to seeing you at the next webinar.
Yes, thank you, everybody.
Thank you. Bye,
Thank you.
everybody.
Bye.
Thank you. Bye.
Thank you.
Thank you.